everyone, welcome back to the Tox Lab. I'm Rebecca.
I'm Rob. So this week we thought we'd have a look at ketamine, a drug that was once just really localised to horses and ravers, but has actually now seen a huge increase in its scope of use. Some people say ketamine is the best drug. I think those people should get off their high horse.
That was actually awful.
But no, in all seriousness, this week we're going to be looking at a few papers looking at ketamine.
Before we jump into today's episode, just a quick reminder that all the papers for this episode will be linked in the description down below. So if you want to do any further reading or check them out for yourselves, you can find them down there. And a quick shout out for our socials. If you want to get in contact with us, give us feedback on any of our episodes, or if you've got ideas for future episodes, you can find us on Instagram at _tox_lab. We also have a page on LinkedIn. For those of you who don't use socials, we also have an email address. You can email us at thetoxlab@gmail.com.
So Rebecca, why don't we jump into the first paper?
So the first paper we're looking at today is looking at IV ketamine treatment for depression in India. So some facts to start off with: 5.3% of people in India are affected by depressive disorder, and their suicide rate has increased from 9.9 per 100,000 people in 2017 to 12.4 per 100,000 people in 2022. So this paper is a retrospective chart review of inpatients with depressive disorder as per ICD-10 codes, which we've looked at previously. And these individuals received ketamine infusion therapy between March 2023 and September 2024. So this included patients with depression and suicidal ideation, those who had treatment-resistant depression, which includes failure to respond to at least 2 different classes of antidepressants for more than 6 weeks at a maximum recommended dose. So to assess these patients before they had their ketamine infusions, they used a clinician-rated Hamilton Depression Rating Scale 17, which has 17 items relating to symptoms of depression that an individual has experienced over the past week. So you'll come out with a different score. So 0 to 7 is equal to no depression, 8 to 16 mild depression, 17 to 24 moderate depression, and greater than or equal to 24 is severe. So these individuals were given 50 milligrams per mil of ketamine hydrochloride in a continuous IV infusion at a dose of 0.5 milligrams per kilo of body weight over 40 minutes. The number of sessions each individual received varied, but they were given at least 3 as an induction, and then in those who didn't respond to treatment was discontinued. And they determined those who didn't respond to treatment as having a score that didn't change, essentially. So from this chart review, they found 28 patients that met the criteria. Mean age was 37 and 61% of them were males. 43% of them had recurrent depressive disorder, 29% had a single depressive episode, 25% had persistent depressive disorder, and 4% of them were bipolar. And half of them had at least one psychiatric comorbidity, so either generalised anxiety disorder, substance use disorder, or panic disorder. And 86% of them had severe depression based on this score.
So ketamine's got a lot of medical uses. It's often used as an anaesthetic in cases of trauma and things like that. But it's also seen use in treatment-resistant depression, hasn't it? So this isn't new, groundbreaking stuff. This has been around a little while now. There are ketamine clinics around the UK using ketamine for depression, for treatment-resistant depression. And so far, I think a lot of the results have been fairly encouraging, haven't they?
Yeah, I think so. So in this study, a statistically significant decrease in score was seen post-treatment. So 15 out of the 28 patients achieved a greater than 50% reduction in their score, and 11 of them achieved what they classed as remission. So they had a score of less than 7, which is equal to no depression. And 80% of them had a substantial decrease in suicidal ideation as well. So it seems like quite a promising effect, and it seems like the ketamine infusion therapy has worked quite well in these people, but it is important to remember that there were only 28 people in this review, and they were also only looking at the effect 24 hours post-treatment, so we don't really have any data on long-term effects and what that might mean days, weeks, months post-treatment.
Yeah, on the one hand, this provides really good real-life data, doesn't it? This is these are real patients that have undergone real treatment and shown a real improvement in their symptoms. As you say, it's a very short-term study. It was a retrospective study as well, so it wasn't perhaps an ideal clinical trial, but this just adds to the wider body of evidence. There are a few studies now that have shown ketamine can be quite effective in achieving remission in depression, which is, as we're saying, this is depression that has not responded to other conventional treatment. I guess this short-term effect in this study does raise the question, is this just a sort of pause in symptoms rather than a cure? Although I think some patients did go back and have multiple treatments.
Yeah, they were, as long as they were achieving some sort of reduction in their score, they were continuing these infusions. But I don't know for how long of a period they were going back and forth, how long they could go before having an extra infusion and things like that.
And as I said earlier, there are now a few clinics, certainly in the UK, that are offering ketamine treatment. As far as I know, it's not available on the NHS, but it is medical supervised, off-label, because it's not approved for use in depression in the UK, but medically supervised use of ketamine for depression. So overall then, relatively positive outcomes to ketamine infusions in this context.
Yeah.
Is this one of the reasons why we're perhaps seeing an increase in use? Famously, Elon Musk has admitted to using ketamine to treat depression.
Potentially. I do know that in the UK, the Office of National Statistics have stated that ketamine use has doubled since 2016, and there's been a threefold increase in use amongst individuals under 25.
So very briefly, I want to touch on the pharmacology of ketamine. We've talked a bit about NMDA antagonists previously. So ketamine essentially blocks a type of glutamate receptor, and that reduces the inhibitory tone on certain neurons. So you effectively turn off certain parts of the brain and turn other parts on. What's interesting about ketamine is it seems to lead to this increase in brain-derived neurotrophic factor, which is a protein that leads to neuron growth. And so one of the hypotheses is that ketamine works as an antidepressant by effectively causing the brain to rewire itself a little bit. Yeah, so unlike other antidepressants, which just seem to do short-term treatment, actually there is, at least the theory is that ketamine actually potentially could lead to longer-term changes within the brain, although I'm not sure we've got much data on that as yet. So why don't we move on to the next paper?
So the next paper we're going to look at today is looking at recreational ketamine use in individuals who have opioid use disorder. So there is a potential for ketamine to be used to treat opioid use disorder and has been shown to help with withdrawal symptoms and can also assist with cocaine-related cravings and withdrawal. So this paper looked at data that had been collected from those participating in an opioid use disorder program in the US. So this included 93 substance use treatment programs across 35 different states. And these covered those over 18 and those that were newly admitted to programs to avoid repeat data collection. So from this survey, they found 86 people who used ketamine and 215 who didn't. And in the group of people who used ketamine, they were more likely to be under the age of 45, more likely to be male, and also more likely to live in suburban areas. 67% of them used other drugs alongside ketamine and obviously their history of opioid use, including cannabis, alcohol, cocaine, MDMA, psilocybin, and prescribed opioids. And what I found interesting is the mean number of drugs alongside ketamine use was 3.89. So there's quite a lot of polydrug use going on in this data set.
So I guess the question was, were they using ketamine to self-treat their opioid use disorder, or were they using ketamine because they were also using everything else that they could get their hands on?
Yeah, that is an interesting point. 15% of them stated that they used it to ease opioid withdrawal symptoms and cravings, and 8% of them were using it to avoid opioid use altogether.
So this is another emerging area, isn't it? The use of ketamine similar to the pharmacology associated with potentially treating depression, this idea that perhaps ketamine could help rewire a brain effectively and reduce some of the addictive behaviours and the addictive feelings that come with opioid use disorder. Yeah, it's interesting, isn't it? Is this effectively self-treatment, off-label use, or is it effectively a coincidence under the polydrug use heading?
I mean, I guess it's probably a bit of both. And it's quite a tricky picture to untangle because they could be using it partly for its recreational use and because it's a drug they can get their hands on, but also because it does come with that added benefit of sort of treating withdrawal symptoms from other things.
Depending on the drug treatment program they're in as well and what testing's being done, ketamine isn't always tested for. So it might well be that there is a motivation amongst some to effectively try and dodge drug tests, which are clearly going to be testing for opiates and things like that.
And out of the people who use ketamine in this study, approximately 1/3 of them reported negative effects whilst on ketamine. So I think about 2/3 of them reported central nervous system problems, so terrors, very intense episodes of dissociation, and some of them even were admitted to the emergency room and hospitals as a consequence of this. So quite severe negative effects of using.
Okay, so let's now move into our third paper.
So this next paper looks at ketamine use disorder. So in individuals who use ketamine chronically and quite a high dose of ketamine, they can experience some quite negative side effects associated with that. So ketamine use disorder is a bunch of different symptoms that can include cognitive impairments, which include structural and functional changes in the brain, including a global reduction in grey matter volume, and individuals frequently report an increase in depressive symptoms. They can also get ketamine-induced cystitis, and that severity of which correlates with an increase in the use of ketamine. GI issues are also commonly reported, and 25% of people experience symptoms such as abdominal pain, also known as K-cramps, which sort of leads to a cycle of using because then people use ketamine as a way of treating the pain associated with these cramps. But what's interesting is that not a lot of people are seeking help for these issues. So this paper quotes that about 50% of people are seeking care for bladder issues associated with ketamine use. And so they've conducted a survey as part of this to try and see how many people who use ketamine chronically are experiencing ketamine use disorder and how people are going about seeking treatment for this. So 274 individuals with a history of problematic ketamine use and ketamine use disorder completed a survey, 179 of which completed the entire thing between November 2023 and April 2024. So some general stats about the individuals who took the survey. 69% of individuals were current ketamine users. 60% of them were not seeking treatment at this point for their ketamine or ketamine use disorder. 48% of individuals were male, and 59% were diagnosed with a mental health disorder. And the average age of individuals partaking in the survey was 28. So on average, individuals first used at the age of about 19. 98% of people were snorting their ketamine and consuming on average 2 grams a day, with as much as 20 grams being taken in a day. Looking at usage between the treatment-seeking and the non-treatment-seeking groups, the treatment-seeking groups used a significantly larger amount of ketamine per day.
And so in effectively ketamine-naive individuals, doses of 30 to 75 milligrams might be considered a dose. So we are talking either large doses or lots of repeated dosing over the course of a day.
73% of individuals were using ketamine as their primary drug of choice and have been using for between 2 and 10 years. And initial motivations for using included wanting to dissociate, self-medicating for depression, and lots of people were interested in the psychedelic effects. And people quote that they continually used as a way to dissociate and to self-medicate and to relax. So moving on to symptoms that people have experienced with their ketamine use disorder. 13% of people who completed the survey reported no symptoms. 60% reported bladder problems, nasal issues. Just under that, 56% reported K-cramps, headaches, and other issues such as kidney issues, gallbladder issues, body aches, liver problems, heart palpitations, erectile dysfunction, brain fog, constipation were also seen. But a whopping 56% of them were not seeking treatment. And of those who did, only 36% of them felt satisfied with treatment for their physical symptoms.
So did this study look at ketamine withdrawal or anything like that when people did try to quit ketamine?
They did. They asked people what sort of symptoms they were experiencing when they did this. So approximately 70% of people experienced cravings and low mood, anxiety, sleep disturbances, fatigue, abdominal pain, and insomnia were also reported among what I would consider more typical withdrawal symptoms. So like sweating, shaking, palpitations, tremors, delusions were all reported as well. So 41% of people who completed the survey had sought treatment for ketamine use disorder. And what I found quite interesting was that people were going back multiple times to seek treatment. So 38% of people sought treatment once, but 16% of people were seeking treatment more than 5 times. And this included going to a specialist addiction treatment provider, but 36% of them were consulting their doctor. And the most common treatment options included outpatient therapy, support groups, inpatient rehab, and holistic therapy. And most people found support groups, inpatient rehab, and outpatient therapy most effective. But about 14% of respondents reported that no treatment was effective in treating their ketamine use disorder.
It's really tricky, isn't it? Addiction services probably aren't really set up to deal with ketamine as a substance. For opioid use disorder, we've got established protocols using opioid substitution. For people with alcohol use disorder and benzodiazepine dependence, again, there's protocols. We can switch people onto other benzos, we can taper them. With ketamine, there's not really anything that acts in the same sort of way. There's no ketamine substitution therapy.
And a lot of people who took part in the survey agree with you. They think there is a need to educate healthcare professionals on ketamine use disorder, because they felt that a lot of people didn't really understand what the problem was. And those who weren't seeking treatment actively emphasised the need for therapy and some sort of medication to aid quitting their ketamine use. So those who weren't actively seeking treatment cited a lot of barriers they were facing as to why they weren't. This included wanting to continue using, which obviously wouldn't be compatible with treatment, but also fear of judgment or their use being revealed to friends, colleagues, family members, things like that. Also a lack of awareness of options, as we've talked about. People know about treatment services for like opioid use disorder, for example, but the options they have to treat their ketamine use aren't widely known. And financial constraints were a big factor in the sort of treatment options people were picking, both in those who were actively seeking treatment and those who weren't. Not a lot of these are available, or none of these are available on the NHS. And so people are having to pay out of pocket for treatment and the treatment options they want. So that's obviously a big factor as to why some people wouldn't be able to go into treatment even if they wanted to.
So 3 different papers all looking at ketamine use in 3 very different situations, 3 very different populations. Ketamine really has gone from a niche club drug / horse tranquilizer, a meme, just say nay. And now we're seeing this use, legitimate medical use in therapy and encouraging results coming out of some of these studies. But as you say, we're also seeing this rise in, particularly amongst young people, off-label use, if you like, street use, whether that is self-treatment for depression or whether that's recreational use. There has been this growing acceptance of use, hasn't there? It's become more popular, it's become more mainstream to use ketamine. And as a result, we're seeing a lot more people, as the third paper showed, needing treatment and having some of these really, really quite severe negative effects. We shouldn't underplay the bladder issues, should we? They are genuinely really, really quite severe. Some people requiring surgery, debilitating consequences of chronic ketamine use. I want to touch on that a little bit. We think it's caused by ketamine metabolites actually causing inflammation of the bladder, potentially even crystallizing. I'm not sure we quite know exactly the mechanism. But yeah, chronic ketamine use has been associated with these chronic bladder problems for, well, quite a while now. But it does seem to be more and more prevalent. We're seeing more cases of people who have got chronic bladder issues secondary to ketamine. I guess the question is are we as a society, on the one hand, promoting ketamine use? Is that leading to this rise in negative effects? And are we pushing down one avenue more? Should we be investing more in treatment?
I think with ketamine being used off-label as a way of treating treatment-resistant depression, more people who suffer with mental health issues are going to be curious as to whether it can help them. And I guess will go out and use recreationally as a way of sort of combating their symptoms. But I don't think it's widely known or widely enough known about all the negative side effects that come with ketamine use. As with any drug, like it's always going to come with risks and negative effects. And if we don't talk about it and make people aware of it, then people aren't able to weigh up the risk benefit of their use.
Yeah, I think that's fair. I mean, this is where we need longer term studies, don't we, on the ketamine infusion therapy. Realistically, though, that ketamine infusion therapy, they were giving people 40 or 50 milligrams. Some of these people presenting for treatment are using 2 grams a day up to 20 grams a day. So there clearly is a difference in dosage between those treatment sessions versus what people are using when they've got free access on the street. I do think the question of treatment services is interesting. Historically, the public health crisis within addiction has been alcohol and opioids generally. And suddenly we've got this new class of drug that's becoming more of an issue and people are now starting to present treatment. So I think there probably does need to be a move within the addiction service community. And I know a lot of my colleagues are working towards that. They're certainly seeing a lot more patients now presenting with ketamine use disorder effectively.
And I think it's also important when people present to like their GP experiencing these symptoms like K cramps and bladder issues, that's something that healthcare professionals made aware of, that ketamine could be a potential cause, and helping not just with the physical symptoms, but signposting to addiction services, because that's kind of where you've got access to help.
Yeah, that's a really good point, actually. A lot of our addiction colleagues are aware of this rise in ketamine, but actually it might well be that GPs and perhaps who are the first line people who are seeing these patients seeking help may be actually much less aware than some of our more specialists in the field. That's a fair point. It's tricky, isn't it? There clearly is a rising public health crisis, potentially. I know the government have asked for evidence to consider reclassifying ketamine from a Class B drug to a Class A drug. I don't know what the outcome of that will be, and I'm not sure what difference that will make. It will clearly place more control on ketamine in general. I did want to talk a little bit about ketamine analogues, because this is a pattern we've been seeing in a lot of other drugs. You know, we've talked a lot on here about novel opioids and novel benzodiazepines. There's a lot of ketamine analogues out there as well. Methoxetamine was a compound that was around many years ago and was originally touted as being more bladder safe than ketamine. There's a few others, 2-fluoro-deschloroketamine, a few other compounds, all very similar in structure. I guess the question is if we do put stricter controls on ketamine, are we just going to move towards one of these analogues? And you know, the evidence from methoxetamine, at least, was that it wasn't more bladder friendly. It still caused some of the bladder issues.
I think with anything, once you control one thing, there's always a real risk of other things popping up. So if it does get reclassified, there is a real chance we might see different variations on ketamine. And what sort of effect they have long term, we just don't know.
Okay, so I think really in summary then, ketamine is showing promise as an antidepressant, but ketamine is also showing significant risk of harm. And I'm not really sure our health services are ready for the potential wave of ketamine use disorder that might be coming its way. So I think we're going to wrap it up here. I do hope you've enjoyed listening this week. If you want to stay up to date on our latest episodes, do follow us on social media or follow us on Spotify or any of the other platforms. It'd be really appreciated.
So you can find us on Instagram at _tox_lab. As I said at the beginning, we also have a LinkedIn page. You can also find us on Twitter. And if you don't use social media but have any feedback or suggestions for future episodes, you can email us at thetoxlab@gmail.com. We'd love to hear from you. And as always, the papers that we've talked about in this episode will be linked in the description down below if you want to go check them out and do some reading for yourself. Hope you all have an amazing week, and we'll see you next time. Bye!